Good morning, good afternoon, good evening to everyone, wherever you're tuning in from around the world. We are delighted you could join us today for this exciting launch event. My name is Uttara Bharat Kumar. I'm a Senior Program Officer at Johns Hopkins CCP, working on the USAID-supported Breakthrough Action Project. 10 Lives, 10 Stories, 1 Message is the result of a competition meant to elicit and share compelling human interest stories that demonstrate the power of social and behavior change, or SBC as we call it, to improve family planning and reproductive health outcomes. A few months ago, 10 Lives, 10 Stories, 1 Message set out to find and support organizations that are passionate about SBC to share how they use the power of SBC to improve, enhance, or amplify family planning and reproductive health outcomes within their programs. And through these stories, we hope to make a compelling case among the greater family planning and reproductive health community for the use of social and behavior change approaches within their programs. So submissions were solicited in English, French, Spanish, and Portuguese, and we received a great number of wonderful stories and submissions from all around the world. An expert panel of diverse global judges from FP 2030, USAID, Johns Hopkins, CCP, Save the Children, and other organizations looked at the stories and evaluated them based on agreed upon criteria to find the top 10. This was not an easy task because the stories were outstanding. The top 5 stories were to be made into video films, and the next 5 were written up as stories. We'd like to extend our warm thanks to the judges who invested a lot of their valuable time in painstakingly reviewing these submissions. You know who you are, and thank you very, very much indeed. So today's event, just to give a quick walkthrough, is about an hour and a half long. I'm sure you won't see the time pass, and we'll have the opportunity to see the short videos from the top 5 entries first. After this, we'll have the representatives from each of the organizations join me on a panel where they will answer some questions about their program. We ask that you the participants who are attending, use the chat box to please add in your comments, kudos or questions, whatever you may have. And we'll have some time to ask a couple of your questions as well, extracted from the chat box and shared with the panelists, and have them respond, whoever can respond. So before we jump right into the program, I'm first very honored to introduce Beverly Johnston, who is Chief of Policy Evaluation and Communication Division in USAID's Office of Population and Reproductive Health. As a member of the office senior staff, her work supports the goals and objectives of the office, contributing to the reduction of unintended pregnancies and improvement of family planning and reproductive health behaviors. Ms. Johnston provides direction and priorities of action for Policy Evaluation and Communication Division's functional areas, including preparation and dissemination of information related to family planning, reproductive health policy, advocacy, finance and governance, social and behavior change, knowledge management, population, environment and development, gender and measurement. Before assuming her current position in 2013, Ms. Johnston served for several years as the office's senior policy advisor. She's worked on global health and reproductive health issues for over 25 years. We're delighted to have her here. Welcome, Ms. Johnston. The floor is yours to make your opening remarks.
Thank you so much, Uttara, for that wonderful introduction. I'm thrilled to be with you all today to celebrate the launch of these excellent stories that demonstrate the power of social and behavior change in improving family planning outcomes. When we think of family planning uptake, our first thought is typically of clinics and commodities and services. However, the health behaviors of individuals, which are influenced and affected by social norms, are an important part of shaping family planning uptake. Social and behavior change approaches include a range of approaches that complement service delivery and can and should be applied across family planning programming. SBC approaches can increase the effectiveness of service delivery interventions. For example, a program to expand long-acting reversible contraceptive methods, or LARCs, in 14 sub-Saharan African countries, coupled service delivery expansion with demand creation activities and saw their annual LARC service distribution increase tenfold over the period 2008 to 2014. There are many other such examples around the world with data to prove the effectiveness of using SBC approaches to enhance service delivery interventions. SBC that is informed by local needs, often developed with community collaboration, is necessary for a country to achieve its family planning priorities. SBC can be used to address factors that influence behavior at all levels of the socio-ecological model, including social norms, gender norms, and policy. USAID's programming often prioritizes working with local partners to achieve many of our SBC goals. Social and behavior change is rooted in global evidence and best practices too. No longer is SBC viewed as a new practice. Investments in social and behavior change have been refined over the last 30 years based on experience and lessons learned. There is clear evidence of SBC increasing successful outcomes in family planning interventions and demonstrating a high return on investment in both the short and long terms, making use of a variety of affordable and innovative approaches. SBC generates a positive return on investment and can be cost-effective compared to other health interventions. For example, business case modeling conducted by Breakthrough Research showed that in Zambia, for every $1 invested in scaling up SBC interventions, between $2.40 and $5.30 is saved when accounting for direct healthcare costs and productivity losses. In Guinea, $1 invested in SBC generates between $2.30 and $6.10 in savings. So USAID sees its investments in SBC for family planning as key in meeting agency and global family planning goals, particularly unmet need for family planning. We recognize that unmet need cannot be satisfied without identifying and tackling structural and systemic barriers to uptake, including inequitable gender norms, child and early forced marriage, and lack of access to information and quality counseling. So as we hear each of the wonderful examples today, we invite you to join us in appreciating, applauding, and amplifying these stories through your own networks so we can broaden the SBC community of practice and make SBC approaches an integral part of every family planning program. So thank you so much. And we're back over to Utra. Thanks.
Thank you very, very much. I think you've captured the essence of why we are all here, and we believe in SBC. It's not just a sort of spare wheel, it's the steering wheel and not a new practice. And there's so much clear evidence of the effectiveness, not just the effectiveness, but the return on investment. Thank you for those inspiring words to kick us off. And I think now, before we move to the main part of the program, I would like to just remind everybody to look in the chat box about how you can listen to this in French, if you would prefer that, and English. So if you go down to the bottom and look at the little globe icon, please choose English if that's your preferred way to listen, and choose French if that's the channel you wish. We have simultaneous translation available. And yes, do introduce yourselves in the chat box so we know who's here. We obviously don't have the time to have each and every one of us introduce ourselves, but we'd love to know who's here. Great. So with that, a couple of quick housekeeping items before we begin the main part of our program. The videos that we'll see today are recorded in English, and Camelia will be providing live interpretation in French, but we will be uploading the videos with subtitles in French, Spanish, and Portuguese in the coming weeks. We will also post the written stories in multiple languages, English, French, Spanish, and Portuguese. And everyone who registered for this event will receive a link to the videos and the written stories by email. So you'll look for that in the week to come. So without further ado, I want to bring us to the moment we've been all waiting for. Let's watch the videos from the 5 organizations and then meet the panelists. Please do add your questions and comments in the chat box, and I will introduce the panelists when we come back at the other end. Thank you. Marcella, over to you.
For many adolescent girls around the world, puberty is the most vulnerable time of their lives, with myriad pressures and challenges that derail their education, their safety, and their futures. Without factual, right-based information about reproductive health and decision-making tools and skills, they lack agency. Consequently, across Kenya, 40% of teen girls are pregnant, 25% of girls drop out of school by the time they reach puberty, and girls' HIV prevalence is 4 times that of boys. These harrowing outcomes have only grown as a result of COVID-19. There is no magic solution to girls' education, safety, and empowerment. These are complex issues requiring well-thought-out solutions. Zana Africa addresses the material aspects of period poverty by providing sanitary pads and underpants, but they also address other issues. For example, when presenting information about menstrual health, they go a step further by providing in-depth, right-based reproductive health education. They provide a larger context and discuss with girls what's happening with their bodies, and talk about issues like consent between partners and decision-making.
Because of Zana, girls learn that they have a choice. They learn that they are valuable and that they have rights. Because of Zana, they know that they have a right to an education, they have a right to dream and to pursue their dreams. They learn that their bodies are their own and that they need to be treated with respect.
Zana Africa's interventions are co-created with girls and community members. They developed an adolescent health and life skills education school program called the NEAR program, whose materials aligned with UNESCO technical guidelines, stories and experiences from girls and communities across Kenya. The content covered reproductive health, family planning, gender and power, mental health, peer pressure, and self-confidence, which are equally important topics for adolescents. They transformed these stories into comics designed for engagement and sharing. Beneficiaries and community members provided feedback on the development of this content, down to the details of the color of the uniform, whether the socks were slouched, and how the storylines ended. The comic books and magazines are part of a health and life skills program consisting of 25 facilitated sessions delivered by self-adults. The comics act as an interactive textbook for both girls and boys. Participating students demonstrated reduced menstrual stigma, improved knowledge of family planning methods, contraceptives, and STIs, ability to name one method of modern family planning, greater self-efficacy, resilience, and decision-making, changed negative gender norms such as the acceptance of spousal violence. Social and behavior change solution co-created with communities can promote positive gender norms and reduce stigma to improve adolescent health.
Challenging socio-cultural norms and limited programming for adolescents and women with disabilities are common barriers to accessing family planning in rural Kenya. Health Right International has shown that home visits by community-based distributors to be a promising strategy to close the gaps in reproductive health care among poor, rural, and semi-nomadic communities throughout the country. discussing reproductive choice outside the home is considered a taboo, so HealthRight trains community-based distributors on how to counsel men and women on their FP choices for shared decision-making.
CBDs were trained for a total of 16 days. They were taken through the national curriculum for community-based distributors. After the training, the CBDs graduated, and this was done right in the village in collaboration with the Ministry of Health county officials. Now we have empowered community-based distributors who understand the need to reach out to every member of the community.
Susan is a young mother of 5 children. As a woman living with disability and a survivor of sexual abuse, she has long wanted to take control of her reproductive health. Connecting with John supported her in overcoming the physical and social discrimination barriers to accessing care.
Wakati tumekuwa tukifanya hii kazi ya kuvisit household, tumetembea wakati mmoja nikakuta mama mmoja ambaye alikuwa mlemavu. Na hilo jambo lilinifurahisha kwa sababu tulipata ni mama mlemavu na alikuwa hajiwezi. Nikamhamasisha na alifurahia sana kwa sababu alikuwa na watoto 5. Na hao watoto alipata kwa njia yenye yeye mwenyewe hakupenda. Akafurahia hiyo mbinu, nikamwelekeza akapenda mbinu ya
mwenye alinipeleka na pikipiki. John alikuwa anakujanga. Susan Cheptarus, natoka Ibosbi. Niko na watoto 5. Ya kwanza hajanisumbua tena.
The work HealthRight conducts is not just connecting women with vital family planning services, but it strengthens the healthcare system to provide respectful care. Shared responsibility between men and women and open dialogue are essential for improving reproductive health and shifting the gender power imbalance in decision-making. Men's role and FP concerns are addressed effectively through outreach initiatives.
Experience yangu katika kijiji changu kufikia mwanaume mwenzangu, tunakutananga sana wakati mwingi kwa baraza. Ingawaje sasa kuna hii magonjwa yanaitwa COVID, lakini kuna vikundi vidogo vidogo katika vijiji vyetu. Tukipata ujumbe kutoka kwa chief, pia napasa ujumbe pale kwa wanaume. Nimepata hata mzee mmoja ambaye alikuwa mchungu sana kwa mama mmoja.
HealthRight's work affirms that providing inclusive education and care to the most disconnected members of one's community and engaging all of its members can transform families and empower women in their reproductive lives.
In southern Senegal, girls dream about their futures, but they face many challenges, including deep-seated social norms regarding child marriage, female genital cutting, teen pregnancy, and limited opportunities for education. Grandmother Project Change Through Culture uses a unique approach, working with grandmothers to catalyze change to help girls realize their dreams. Girls live in families and communities deeply embedded in culture. Girls alone can't change the social norms that affect them. People often assume that grandmothers are set in their ways and will never change. Grandmother Projects discovers that grandmother can not only change but can become a powerful force for change in communities. To change ingrained social norms, Grandmother Project engages adolescents, adults, elders, men and women, religious leaders and health workers in dialogue and consensus building through various activities such as intergenerational forums, workshops with grandmothers and teachers, forums with girls, mothers, grandmothers and female teachers grandmother leadership training. A 2020 evaluation by the Institute for Reproductive Health at Georgetown University concluded that grandmother projects intergenerational and grandmother inclusive approach has contributed to changing social norms. These evaluation results clearly show the positive effects of the program in communities involved in the program compared with those not involved.
Larama ala hede ko tampere bolde ko dum taki min boppi do cugal dengel dira do nannak e wani do min badani sabu ko bittere amen tan bittere amen.
FGM has been abandoned here thanks to the grandmothers. When the grandmothers decide to stop the practice, no men could oppose their decision.
Wada be dora men étape par étape ha men bawna hore amen wadane de goddum takangal hay goddo yi holli men dum ham mawbe amen be kollir men kollirde ni men bawbe no nabe ande dum dedi lawdi wadi ha ussi ko nde fedde adde ade lawdi ussi jo kam dingala ka be dedi law
This work shows that grandmothers can be a positive force for change for girls. Powerful grandmothers exist in all communities, a resource for change that should not be ignored. Social and behavior change empowers grandmothers to be respected change agents in their communities and advocate for their grandchildren.
It was already a challenge to connect women with family planning and reproductive health services in Pakistan, particularly postpartum women and post-abortion family planning patients when COVID-19 created an added barrier. Pathfinder International launched a robust campaign to educate women about the availability and importance of family planning and reproductive healthcare services. Due to conservative social norms, the facilitators at Pathfinder understood that it was crucial to involve community members, policymakers, and religious leaders in their discussions as they developed the campaign, both to get their input and ensure that the messaging was impactful. As it turned out, the focus group itself helped recruit what would become one of Pathfinder's strongest voices.
Yes, sir. Asanja ta aam khandani mansuba bandiya ke kudurti amal asa sher shar samjhando hoyus sir khandani mansuba bandi baad ta uha gal mujhe ilm mein hui ta sharai tarah sa maa ke bin salan tai baar ke thanj piyan ghurje focus group डिस्कशन दौरान निया कदम डिस्ट्रिक्ट को आर-डीटर ॿुधायो त उहो थञ पीअण वारो अमल असल में ईंदड़ 2 सालनि ताईं हमल रोकण जो कुदरती तरीक़ो आहे जेको पिण क़ुर करीम में बि मौजूदु आहे.
As a person of influence in the community, the Imam was able to use the mosque as a platform for delivering messages to men around sexual and reproductive health and rights, family planning, and gender-based violence.
पेश इमामन जे जनरल सेक्रेटरी ज़िले जे कुल 20 मस्जिदनि जे पेश इमामन खे आमादा कयो त उहे पैगाम माण्हुनि ताईं पहुचाइनि ऐं उन्हनि ताईं पैगाम पहुचायुनि मुंहिंजे जमायतिन उन्हनि पैगामनि ते अमल कयो ऐं कोरोना वबा खां बचण वारनि तदबीरनि ते पिणु अमल कयो। ख़ानदानी मनसूबा बंदीअ बाबति पंहिंजे घर वारनि सां ॻाल्हि ॿोल कई ऐं कुझु साथियुनि जा ख़ानदानी मनसूबा बंदीअ ते पिणु अमल कराइण जो मशवरो ॾिनो।
The campaign also consisted of social media marketing, celebrity-led mass media PSAs, circulation of key messages through local digital networks of community health workers, community-based signposting, and community PSAs through mobile units. The campaign reached nearly 3 million people through social and mass media, 2.5 million through vehicle announcements, and 121,000 through mosque announcements. Influential community leaders can use social behavior change approaches to encourage their peers to consider postpartum family planning.
Research showed that 78% of 20 to 24-year-old youth in India were not using contraceptives. And condom sales declined by 40% during the COVID-19 lockdown. To address misconceptions and stigmas associated with buying and using condoms, Soplus developed a music video and social media campaign directed specifically at Generation Z to normalize uses of condoms and conversation around contraception.
The first and primary thing was to not make this communication preachy or boring or something which is, not exciting to them. And hence came the idea of talking to this, this group of individuals, this younger TG that we are talking to, in a language that they understand and resonate the most, which is the language of music. And hence we came up with this whole idea of creating a campaign which had a very, very, very millennial touch to it in its communication, very contemporary. So condom hai. Treatment of the film was also, if you look at the sets that we've put together in the film, bring alive, very attractive space where the girl and the boy are seen going around. So it showcases a space where this audience would connect with, something that they aspire for, and something that they're very happy to share, with their friends, and something that isn't going to be a hush-hush and isn't going to be a taboo.
The music video, along with several social media graphics, was timed to launch around Valentine's Day on YouTube, Facebook, and Instagram. 120 social media influencers have amplified the campaign by creating a dance challenge for their followers. The campaign reached 23 million people, at one point becoming India's #1 trending topic on Twitter. Research shows the campaign made conversations around condoms more acceptable in social spaces and amongst peers, with a 60% change in how youth perceive condoms, from a pleasant dampener to a consent seeker, making a smart choice. The share of condom conversation in the universe of sex-related conversation in India on social media saw a 64% jump, which is a huge achievement given that condoms are a taboo topic in India. The Soplus campaign showed that meeting your audience where they are at and making the message accessible not only got their message heard, but empowered their audience to make informed choices.
feel like I should say welcome back. I hope all of you felt as transported to those different contexts as I did. Those were 5 very exciting different stories. And now it's time to welcome our 5 panelists. Megan Mukuria, co-founder and CEO of Zana Africa Group. Hawa Abdullahi, program manager for Health Right International. Judy Obel, founder and executive director, the Grandmother Project, Change Through Culture. Manal Khan, marketing, communication, and learning manager for Pathfinder Pakistan. Komal Khanna, former chief of party Shops Plus India, a USAID project of Apt Associates. Welcome. I hope you can all turn your cameras on. We should have you at the top of the, yeah. Great.
We just need the host to do so.
Great. Hello, Manal, Komal. I think Judy's not able to turn her camera on.
Mine's saying I need the host to turn it on.
Ah, okay.
Yes, I'm working on that.
Okay, great. Okay, so I'll kick off with a couple of questions to all of you, and then we can take a few from the chat if there are any, but if not, we'll spend about 10 minutes chatting on this. And the questions are as follows. Do you see your SBC intervention or idea scaling up within or beyond the current level where it's at? That was the first question. And the second question is, what do you hope the audiences will take away from your stories after watching these very captivating stories? And maybe I can, who would like to go first? You can just raise your hand if you're ready to answer, and I'll just call on you. It's always hard to be the first. Feel free to unmute. Go ahead, Komal, and then we can go to Judy. Yeah.
So your first question was on the scale up and sustainability, right?
That's right.
Okay. So as we understand, sustained social behavior change communication campaigns are imperative for not only India, but for the whole world if we have to fulfill the FP 2030 commitments. And as we have proven in our project, the private sector can play a very important role in supporting India's 2030 commitments. So our campaign, the condom campaign, had a very short burst of over 3 months in the social and digital media. This was during the COVID pandemic, and has still moved the needle. As resources are limited, sustained campaign efforts can be made through partnerships to broaden the reach and effect of the campaign for sustainable behavior change. And I'd like to share a case and example where a condom campaign was collectively supported and launched by India's top condom market players through the Condom Alliance Coalition, which Shops Plus had only created. And the condom campaign was amplified on social media handles of Instagram, Facebook, YouTube by these condom marketers. And we feel that the condom campaign can further be sustained by the condom marketers, and they will carry it forward. So we have transitioned this campaign to the condom marketers. Thank you so much. That's the first answer.
Thank you. Maybe we'll come back to you for the second. Judy, did you want to go next?
Yes, sure. So your question is, what are the prospects for replicating, scaling up this, our approach in other contexts, right? Yeah, I think that as you saw in our video and the Onion model, our program is entitled Girls' Holistic Development, that promotes changes in norms related to girls' education, child marriage, teen pregnancy, and female genital mutilation, cutting. And so I think in all contexts, in terms of the relevance of our the replicability of our approach in other contexts, I think in all contexts, girls are not alone. And while it is important to increase girls' knowledge, confidence, and empowerment, they're influenced very much by those around them. I think this is true in all contexts, particularly in the global South, in Africa and beyond. And so our approach involves, as was I think mentioned a bit in the video, involves 3 generations of elders, adults, and adolescents, men and women, religious leaders, teachers, health workers, really an inclusive approach, which I think has widespread relevance in other cultural contexts. We do training of other organizations in West Africa. We've done this with colleagues from governments and organizations in French-speaking West Africa. And in all cases, they have felt that the cultural context is similar in terms of those influences on girls and the potential for replication. And secondly, we refer to our approach as change through culture. I think in all societies, cultural identity and values are very important to people. Sometimes in programs, they're perceived as an obstacle or constraint. We view culture as a resource, and the starting point in our work, and I think it would apply in all other contexts, is to identify who are the culturally designated authorities and influencers that should be involved. And I think the way we see it, lastly, it's important in changing social norms to identify who is involved in, who's responsible for perpetuating those norms, and also who has the power to change those norms. Thank you.
Thank you, Judy. So important to consider the social norms and changing them. Who might like to go next? Manal, please go ahead, and then Hawa.
Great. Thank you so much for firstly giving us the opportunity to present our work, and congratulations to all the inspiring stories that have come forward. I just wanted to take this opportunity to say that we do see this campaign that we've put together scaling, because we did receive government endorsement while we were preparing the messages that were disseminated, and the government does often work with mosques to do similar campaigns. So we do see that. We also see male engagement being a priority for the government, which is also important when we are trying to meet our FP 2030 targets. So, but what I wanted to talk in more detail was the second question that you had mentioned, which was about our what we hope for the audience to take away from the story. So there are 2 key takeaways that we would like, we were hoping that come forward with the video that's been developed. And one of them, the first one, is that interspousal communication and couple communication for joint decision-making is very important. But unfortunately, in patriarchal societies and conservative societies, that often doesn't happen. And in order to enable social and gender norms, programs have to take into account men as a critical audience and position them as enablers for women's right to access family planning services. And the second key takeaway is that to encourage this new household norm of joint decision-making, we need to take input from community popular leaders. It's very critical. And in a social setting like Pakistan, often there's a notion that religious leaders are can be considered a barrier to family planning knowledge and family planning information. But they also represent a great opportunity where the clergy can be engaged as a secondary audience to endorse messages for men. So what we're hoping with this video is that, and the campaign altogether, is that it will help in creating a favorable shift in perceived norms for men related to household decision-making, and then create new norms for leaders in the community for encouraging and expecting men to engage in interspousal communication for ensuring the health of the family. Those are my 2 cents. Thank you so much.
Thanks very much, Manal. Important points. Great, thanks. Let's move to Hawa.
Thank you very much, Utra. In response to the question that you're asking about sustainability and scale up, what we've been able to do is a lot of advocacy at the county levels and at the national level, because the plan was, first of all, to get the stakeholders talking, have the conversation, and start looking at persons with disability as people who've been forgotten for the longest time, and how best we can incorporate them into the system to allow them to get the service and make the service accessible to them. And
so sorry to interrupt, Hawa. Our colleagues who are on the French channel are having a hard time hearing you. Have you selected the English translation channel on the bottom right corner? Do you see the globe? If you could select English, that would be super. Thank you so much, and sorry to interrupt. Please continue.
Sorry about that. So as I was saying, in response to the sustainability and scale-up question, what we've been able to do as HelpRight is to have the conversation going at both at the national level and at the county level, because the intention was to have people talking about persons with disability with regards to access to family planning and SRHR. And so we have had a lot of engagement, and we've brought in on board other stakeholders who were in the past not incorporated in health issues and SRHR. That includes the National Council for Persons with Disability. And so these are people who are very resourceful, and when brought on board, then it becomes possible for the two entities to sit together and come up with a conclusive solution on how to go about the whole idea of social inclusion with regards to access to SRHR services. And so what we've also been able to do, we have developed a county-specific SBCC strategy that has been shared with the counties, and they can use this to reach out to the specific target population with the messaging to ensure that there is buy-in. And for the first time, we now have the county health officials looking at ways to improve the structures so that it allows for persons with disability to actually access care and messages. And they are very small and minor, but very impactful, things, like as simple as just understanding sign language to allow them to be able to properly communicate with persons with disability, allowing for the use of ramps at the facility levels, and also making sure that we have wheelchairs available, and these people with disabilities can be able to actually just get into the facility and get the messages from the healthcare workers. We've also capacity built the stakeholders at the community level, that is the community-based distributors and community health workers, and also the decision makers at the county level have been trained on social inclusion. And so this is a skill that we're leaving behind with them, even after the project exits. And so we hope that it can be able to generate more traction and also keep the conversation going. Thank you very much.
Thank you so much, Hawa. I think it's important to involve the policymakers and stakeholders for some lasting change, and that's a very important point you make. Thank you. Megan, over to you.
Yeah, fantastic. Thank you so much. It's so great to be in such wonderful company with the panelists and everybody on the call. So thank you. Let me start with what the audience can take from that, and then our scaling strategies. Very briefly, menstrual health is the most fundamental, menstruation is the most fundamental indicator of human health for females. And yet it's often the time that girls' lives just shrink in what's possible for them. And it's seen as such a taboo in different ways, but pretty universally, from the US to Kenya to India and others. And I've been at the forefront of this issue for the last 2 decades. And it's really exciting that we've had this randomized control trial, because we're really able to add to the framework of how we can leverage this moment in time for youth and this particular issue to really accelerate changes in gender norms. And what we found was that it's not even so much about talking about pads keeping girls in school, but it's actually when you provide pads to girls and knowledge, as well as give them experiential understanding of breaking these taboos, such as being able to actually do sports because they have safe products and they're empowered to do that, then they actually not only change their perception about these menstrual taboos and start advocating for that, but they also recognize the concept of gender norms. And so we found that we changed all 3 of the other gender norms that we were measuring. And we think it's because of this, that they can be able to shift their perspective of what society expects of them versus what is their human right, and be able to be advocates in their communities for their positive human rights and bring others with them. We also found that boys change their perspectives tremendously. For example, boys that didn't go through our intervention said that, girls are created by God to do all the household chores. Whereas afterwards they said, well, actually, boys should do all the same things because girls also need to study, right? So this onset of puberty and the opportunity to talk about puberty education and menstruation in particular, and to provide that intervention, really unlocks this whole host of changes quite quickly, because we managed in just 18 months, just 25 facilitated health sessions, to change all 3 measured gender norms and knowledge of family planning to spontaneously remember at least one form of modern contraceptive. So this vehicle of menstrual health, whether our curriculum is adopted by anybody or not, is a real gateway into this transformation. And being able to talk to adolescents just about their body before it's their body and anybody else's body is really empowering from that human rights framework. And then, as I think Judy was saying, then it allows the culture keepers and things like that to dialogue about these issues and to think about what is aligned with human rights and with culture, and to see culture as evolving and not just static. So I think that is our most important takeaway from this. We've always designed everything at scale. We're a small social enterprise, and we've always wanted to be addressing gaps and then helping others to scale them up. So we've actually scaled this program with World Vision in Western Kenya with 40 teachers. And we discovered from that the trauma that teachers have and the need that they have to be supported to process their own sexual and reproductive health and rights experiences. And now we're working with government on trauma-informed schools. We're also talking with the government, with the Teacher Service Commission and the Kenya Institute of Curriculum Development, about incorporating this into the government curriculum, because ultimately government is a tremendous bearer of, the responsibility for addressing these things systemically. But last, I really believe, as an American who's lived in Kenya for over 20 years, that Africa is a solution center for the world. And the experience of adolescence is completely universal. And so what my real aspiration would be to find other partners who can scale this not only across other components of Africa, but that we could take this story-based framework and add stories from other cultures and create a universal kind of new rite of passage to replace some of the rites of passage that have been lost, so that we can address other negative social norms such as racism by seeing all of us as one human experience through this process.
Thank you, Megan. I think what you touched upon regarding gender, underlying gender norms, and addressing them as a gateway behavior for looking at how young women see themselves, advocate for themselves, and indeed young boys in the community look at issues, because that definitely is a gateway behavior for family planning, choosing a family planning method, of feeling your reproductive rights as something important. So thank you very much for raising that issue. There is a specific question here for the Shops Plus program, and maybe I can direct this to Komal. Did you notice a diversity in responses to this effort from different states within India? I'll let you take that question before we move to the other ones.
Yes, of course. There are some states where this, the social digital media is more effective than other states, and we had targeted, marketing being done in different medias across different states. And we also used the PR approach. So we had the local publications where we were amplifying the messages of this campaign. So yes, there was diversity in the responses.
Thank you. That is predictable, but I think it's good to know. And some of you have answered this question about any plans or thoughts about sharing it across borders, to other countries. And so I think before I circle back to that question I would like to see if anyone else would like to answer the question about key takeaways. Judy, you said you had wanted to share something, and then perhaps Hawa. Go ahead, Judy.
Yes, yeah, okay, got it. Yes, I have two important takeaways that I wanted to share from our work. I think that our work in West Africa, primarily in Senegal, reinforces the idea that families are very important to girls and to adolescents. And therefore, a key piece of our work is an intergenerational approach. I think that an intergenerational approach that increases listening, dialogue between generations so that consensus can be built regarding the need for social change related to girls' education, child marriage, etc. I think often programs focus perhaps only on girls or primarily. And in fact, when girls are empowered and have knowledge and confidence, but if it hasn't been an intergenerational approach, it can in fact create conflict within families and communities. So the first element is an intergenerational approach. And the second one, of course, as a Grandmother Project, Change Through Culture, I need to say something about grandmothers, because we have found that, in Senegal, but I think across Africa and perhaps other areas in the world, grandmothers play a central role in the socialization of girls. I think this is a fact that is often ignored. And what we have found that when recognizing their role, using an approach based on respect, dialogue, sharing new information, that they can in fact be very open to change. They in turn can be empowered to influence family and community decision-making. They can become, what we have observed and documented, they can become catalysts really for change in communities related to girls' education, child marriage, teen pregnancy, female genital mutilation, and other issues. Thank you.
Thank you very much, Judy. Hawa, over to you.
My key takeaway points are 4. First, I would wish to emphasize the need to look at women with disabilities as people who face multiple intersecting forms of stigma and discrimination, especially looking at a simple thing like just going to access SRH. For most women, it is usually, most women with disability, it is very dehumanizing because they have problems, especially, for example, a woman with an impairment of hearing. They go to the hospital and they have to actually be accompanied by a caregiver just to be able to communicate to the healthcare worker. And sometimes that really impedes the privacy because they have to go with a translator. Also, women with disability have sexual and reproductive health rights needs that need to be recognized and addressed by all government actors. And the third point being community healthcare workers and community-based distributors are pivotal to healthcare workforce. And it all is, of course, surrounded by the fact that the right to health is universal and care should be accessible to all.
Absolutely. Well, thank you very much for that point, and also Judy for your point about noting and using the intergenerational relationships and building on them to as Danette points out in the chat, learning and growing together is really important, because I think these are great resources we have in all of our communities. We need to recognize them better and see how we can build on them. Thank you so much. I think we don't have a lot of time for anything more. If there's anything compelling any of the panelists would like to share before we switch to the next segment, please do so. We have another minute or so, and then we will switch over.
I'll raise a hand and say something briefly. I think what I see across this is really just co-creating with the end users in mind, right? And I think most of us who are on this call already resonate with that. But just to underscore, I think it's so easy for projects to come from outside and try to solve a problem, or even from inside and try to solve a problem without understanding the culture, the barriers, the ways people learn, the relationships that are central to shifting those changes. For us, we decided to deploy comics and real life stories and reimagined a textbook as a magazine, which the government just was blown away with because it had all the rigor of a textbook matrix for impact and outcomes. But it was fun, and even the adults wanted to read it, right? So I think we can get really serious, but also just ensuring that our communities that we're trying to have interventions with are having fun and feeling like they're learning and growing and they're being respected, as Judy said. I think it's just so central. And when I started this, I didn't even know what social and behavior change communication was. I didn't know the term. We were just doing it because we felt like everything needed to be girl wrought and community wrought. And it's so wonderful to find a community of like-minded people that value that. And I just want to really underscore that, like letting the community lead because they have the answers.
That's a great note to transition on, Megan. Thank you so much for that. I think looking at social and behavior change as not just as a combination of science and art, really, because we had to bring the rigor as well as the creativity, the entertainment, and keeping the audience at the core of it all along. I think all of the 5 panelists here have shared stories from their organizations that have truly showcased that in a wonderful way. And we are now about to move to 5 more stories that are about to showcase the same in their own ways. So I invite you to join me now in listening to the written stories. And these 5 stories, which obviously we cannot share because they're written, you will receive the links to them later, but we'll hear now from each of the organizations where the stories came from, so they may introduce themselves and tell us just a little bit. And then we'll follow it up with some discussion with those panelists as well. So Marcela, over to you.
Here is Mariam Dekite. I am the technical advisor for research, monitoring, evaluation, and learning on Passages project. I've been working on TG since the beginning, and we are very happy and excited that TG is selected among the 10 best stories. Thank you.
Okay, my name is Mustafa Kano, the country health coordinator for Gold Sierra Leone. Gold Sierra Leone has been using the community dialogue where we actually meet with community people. We use participatory tools to engage them. With the community dialogues, we also have what we call focused dialogues. Based on the issues that are raised, we also identify subgroups within the communities like teachers, religious leaders to engage them separately. We have also used a strategy we call the male engagement, where we actually identify male champions who are promoting positive ASRH behaviors in the community. So we use them to actually reach to other gatekeepers and also adolescents.
Hi, my name is Taziro Ashipeta. I'm Director of Programs at Family Planning Association of Malawi, FIPAM. FIPAM aims at promoting access to comprehensive information and integrated services of sexual and reproductive health, HIV, sexual gender-based violence, targeting people of reproductive age 15 to 49 with a focus on the youth. Community engagement, interpersonal communication, communication awareness campaigns, and media coverage are some of the SBCC interventions that FIPAM is putting in place currently to penetrate barriers to quality information and service uptake. Thank you.
Hello, I'm Dr. Susan Tino. I work with IntraHealth International on the SAPCA project in Uganda, which is the scale up and capacity building in behavioral science to improve the uptake of family planning and reproductive health services. we found that there's a low uptake of family planning among postpartum women in our region. And so as a project, we conducted a research to identify the barriers to this low uptake. And from the barriers we identified, we designed an intervention that involves a game that is played by men in the community and facilitated by VHTs. And then they're given a planning card to go and discuss with their wives and go to the facility to receive a method. So in our story today, we are sharing of how the VHTs have actually impacted these communities through these games, and it has led to an improved uptake of these methods. Thank you. I hope you enjoyed this story.
Hi everyone, my name is Herbert Male. I work for Momentum Integrated Health Resilience in South Sudan as the Social and Behavior Change and Gender Advisor based in Juba. I am grateful to USAID, Breakthrough Action, and Family Planning 2030 to be part of the dedicated and innovative team moving the global family planning agenda forward through the power of social and behavior change. The most recent data shows that adolescent marriages and fertility are very high in South Sudan. More than half of the young women between the ages of 20 to 24 years were married or in union before the age of 18 years, compared to roughly one-third throughout sub-Saharan Africa. In addition, approximately 1 in 4 young women in South Sudan gave birth before turning 18 years of age. Social and religious norms combined with local realities contribute to the unmet needs for contraception for adolescents. To address these issues, Momentum's integrated health resilience engage community leaders, community health volunteers, and dedicated family planning providers in transgenerational dialogue with the community members. The dialogue sessions resulted in addressing fears, myths, and misconceptions about family planning and improved communication between adolescents, their peers, and their parents. In the end, the sessions ensured approval by parents for adolescents to use family planning and other sexual reproductive health services.
Thank you very much to the panelists for their introductions. Let me reintroduce the names. So since some folks from the organizations are different than the ones that were introduced here. Mustafa Kalon, from the health coordinator for GOAL Sierra Leone. Mariam Diakite, monitoring and evaluation and research and learning advisor for the Institute for Reproductive Health. Male Herbert, SBC Gender Advisor, Momentum Integrated Health Resilience. Donald Makwakwa, Executive Director, Family Planning Association of Malawi. And Susan Tino, Project Manager, IntraHealth International. Thank you very much for joining us today as panelists so we can chat and maybe you can answer a couple of questions. We ask that you all please turn your cameras on, the 5 panelists, so that we may have you on top of the screens. Welcome, a warm welcome. So since we didn't have the video opportunity to share the fuller story, maybe I can ask the panelists, each of you, in the order that I read out your names perhaps, to just tell us a little bit of how SBC really informed the design and implementation of the project or the program. What was unique about the SBC approach? What extra element did the SBC approach bring to the program to enhance results? And later, but perhaps we'll ask you the question about what do you hope the audiences will take away from your story? So first, the question about what was unique about your SBC approach? What extra did it bring to the program? Perhaps I can call on Ms. Start with Mustafa.
Okay. Good afternoon.
Good afternoon.
Yeah, so
please go ahead.
Yeah, okay. The unique thing about the SBC approach we used to actually engage not only the adolescents but also other gatekeepers is that the community dialogue we use participatory tools, which we are really engaging, which allow the community people themselves to have input to identify the barriers identify the issues around access or people, adolescents having access to family planning, both the cultural barriers, but also the provider-based barriers. So that was really a unique thing, because they will look it at their own context and also provide solutions that are unique to their own setting. So in as much as we are doing this in different localities, we have different solutions which were really unique to different localities. So that was really the unique things, because we did the community dialogues, and with the community dialogues, we have focused dialogues. We are looking at subsets of communities, but also we did identify male champions who we are actually using to actually reach other male. And then we have religious leaders who were identified by the adolescents themselves as being really influential, people who can really negotiate or change the social norm, the value system within the community.
Great, thank you. So champions who were identified from within the community, from the beneficiaries themselves, so to speak, so that young people were identifying who their opinion leaders were, and so on, and using male role models to share. That's a great angle. So what kind of message do you hope people who see your story or read your story would take away, Mustafa?
Okay, thanks for that. One of the stories probably I really want to, the takeaway message is really, I know we all looking at whether this, whatever approach we've been using is scalable. First of all, we had engaged an institution that is actually called the National Secretariat for the Reduction of Teenage Pregnancy, a multi-sectorial institution which houses like representatives from like 6 ministries now: the Ministry of Education, the Ministry of Youth, the Ministry of Gender, the Ministry of Local Government, the Ministry of Health and Sanitation. So with this, we were able to like not only looking at the service provision angle, but we were able to also like try to influence the social norm. So whereas you have the service, you are able to like advocate for the services to be available, but you want to also generate demand to actually get this. So that's in itself will facilitate sustainability. But above all, we were able to like have a cohort of a network of young people who now are advocates, who have the courage to actually like advocate for their own rights, meeting duty bearers, dialoguing with them so that they are able to like discuss the bottlenecks around sexual reproductive health and rights.
Great, thank you so much. That intersectoral approach in Sierra Leone and youth advocates, definitely inspiring. I'm sure everyone is looking forward to reading that story from Sierra Leone. Thank you very much, Mustafa. So we'll move next to, sorry, let me just, let's move next to Mariam. Tell us about your program. Also just give us the country context, because when I introduced you, I didn't mention which country, so please do to give us that as well. Go ahead, Mariam.
Merci. Bonjour. Oui, avec notre approche qui s'appelle Terikunda Djekulu, que nous appelons TJ, c'est une approche qui a été expérimentée au Bénin et maintenant est dans sa phase de mise à échelle au Mali. Donc, c'est une approche qui combine l'approche de SBC avec l'approche de réseau social afin de réduire les besoins non satisfaits en planification familiale
Pour cela, on fait face aux normes sociales qui est lié aux facteurs de besoins non satisfaits en planification familiale. Du coup, l'approche même, on identifie les acteurs influents dans la planification était tabou à la fois au sein du couple et aussi dans la communauté. D'utiliser en cachette. D'autres on cherche active pour bien comprendre le contexte de besoin. Ensuite, on a
I think we may have lost her. Yeah. I think we've temporarily lost Mariam. Let's circle back to her while she gets back on. Sorry about that. Let's move on to Male Herbert with Momentum Integrated Health Resilience. Welcome, Male. Floor is yours.
Thank you so much. Momentum is a 5-year global project that is funded by the U.S. Agency for International Development. And MA is part of the Innovative Awards to holistically strengthen quality family planning and reproductive health, maternal, newborn, and child health in 40 countries around the world. The goal is to reduce maternal, newborn, and child mortality and morbidity, and to increase resilience of families, communities, and the nations. In South Sudan, Momentum operates in both the health facilities and the communities through the Boma health workers. And again, we also do work together with the partners implementing health, that is the Health Full Fund supported partners and other World Bank supported partners. So when we design our SPC design, we are able to conduct some surveys to understand the current SPC situations within the country, where Momentum Integrated Health Resilience conducted the social behavior change mapping in supported counties to understand existing SBC activities, the SBC materials, the stakeholders involved, the perceptions, beliefs, and attitudes in the communities among groups, including the religious, the community leaders, and other stakeholders. We were also able to conduct family plan social norms assessment to gain a deeper insights into the deeply entrenched social and cultural norms related to family planning, gender-based violence, among others. These activities, in addition to the secondary desk reviews, informed the design and implementation of this particular activity. As you have known, that South Sudan has a very high adolescent fertility rate and at the same time very high pregnancies within the country, where more than 50% of the young women between the ages of 20 to 24 years were either married or in union before the age of 18 years. And this is compared to roughly 1/3 throughout the sub-Saharan Africa. Again, about 1 in 4 young women in South Sudan gave birth before turning 18 years of age. There are a lot of barriers that limit use of family planning services, and which can include the social norms, the religious norms, the gender inequality, the low socio-cultural status, the health system barriers contribute to the unmet needs of contraception within South Sudan. So the use of social behavior change that we have engaged in was intended to understand the key behaviors contributing to the low uptake of family planning and reproductive health services among adolescents, youth, women, and men of reproductive age. Momentum Integrated Health Resilience emphasizes the importance of social behavior change to address barriers to the use of family planning and reproductive health services, create demand for these services, and provide supportive environment through community engagement approaches. So what we did was to engage, knowing that we have a very high unmet needs of family planning among the adolescents, we engage in cross-generation dialogues where we engage the mothers in dialoguing with the health providers to understand the basic facts about family planning, and this in turn will allow their daughters or their sons to access and use family planning services. You know, South Sudan culture is a reserved culture, and most decisions for use of family planning are either made by the parents, basically the mothers or the husband or the fathers of these girls. Again, even the mothers who are married, for them to access family planning services, most of the times they may need a consent from their husbands. We therefore engage the community leaders in dialoguing with the providers and at the same time the beneficiaries so that they're able to understand, have the right information about family planning, because we do understand that there are a lot of misinformations and misperceptions about family planning, which acts as a barrier in accessing and use of these services. So our design was to engage in dialogue sessions where we provide information at community levels, make use of the community leaders, and make use of the religious leaders involved, including other non-informal medical practitioners within the communities in dialoguing and passing the right information so that adolescents can get access to services. Women are given a fair opportunity to access these services, and now we reduce the cases of unwanted pregnancies, which contributes into early marriages.
Great. Thank you very much, Male. That's a helpful overview. And I think everyone will look forward to reading the fuller story in the written story that will be shared with you. So given that we're getting closer to time, I would request the remaining panelists to take about 2 to 2.5 minutes each. And then we'll come back at the very end, Mariam, because sorry, you dropped off. We'll be able to give you some time back just to finish your story. Just 1 more minute to finish it up. But let me go to Susan and then to Donald.
Thank you, Kumar. Yes, SUPCAP is a project implemented in Uganda, and that is the scale up and capacity building in behavioral science to improve uptake of family planning and reproductive health services. It's implemented by IntraHealth in partnership with Ideas 42. And what we identified was first the barriers to uptake of postpartum family planning. And once we identified these behavioral barriers, we then found that an SBC approach was the best fit to actually address these barriers. And so we designed an intervention that involves an educational game. And this educational game is played by men in the community, facilitated by the VHTs in that community that relate with these men and they meet day to day. So after they play the game, they get to learn a lot, and then they're given a child spacing planning card. With the information they've been equipped during the game, this empowers the men to broach a conversation with their partners using that planning card back at home. And so after that communication, they're able to go to the facility, have an engagement with a health worker more, and be able to take up a method. So we found this really unique and special as it really engages the men and improves the couple communication. And so coming to the key takeaways is that is one of the things we're seeing that for us to really improve family planning uptake and involvement of men in reproductive health services, we have to actually improve the couple communication. And it's something that Manal highlighted in the earlier stories as well. So couple communication is key, but also, to really speak that VHTs are vital and key in implementing these multifaceted approaches. They play a vital role, and it would be good to actually involve them, involve the community and ensure that whatever we design is actually embedded within them and improves the health outcomes. Thank you.
Fantastic, Susan. That was very succinctly explained, and I think you hit the highlights very well and shared the key takeaways. We are using SBC as a sort of way to get men to come to the health facility, but also encouraging the couples communication, which is an important component. Thank you very much. Donald, let's move to you.
Thank you very much. Sorry, I'm in a very unfamiliar place because I'm in transit, so I just had to find some space for me to attend to this important session. Yeah, so for Malawi, just like others have said, we have a very big problem around young people's uptake of sexual reproductive health services, including family planning. And as a way of dealing with some of those challenges, which include existing myths and the misconceptions, as well as the challenges related to the community gatekeepers, as an organization, we have enrolled the work of community health workers, including a cadre that we call community health reproductive promoters. These are basically people based in the communities. And as a way of addressing issues to do with young people, we have encouraged these community health workers to do door-to-door kind of activities, which include creating awareness, generating demand, as well as providing services, particularly if the services that this cadre is allowed to provide is available. The reason why we have encouraged this to do door-to-door activities is to reach out to the young people together with their families, particularly their parents, who basically have been one of the challenges why they couldn't get the services. But if they are reached together with their families, it means in terms of awareness creation and demand generation, this is done together with their families, and who in the end are becoming supporters for those young girls and young boys to continue accessing services. Apart from the door-to-door work that the community health workers, including the CRHPs, they're also working with youth clubs as well as communities in wider community to ensure that they raise awareness, create demand, and also provide referrals to services. As you're aware, this cadre is only allowed to provide some of the short-term family planning methods. And also some of the SRHR services are not provided by this cadre. So we encourage them to do referral to the nearest health facilities, much so to FIPAM's mobile health clinics, which are available, and the young people are encouraged to book an appointment with these mobile teams so that they can get to know more about the available methods of contraception and make their informed choices based on the counseling that they get. For us, what we have noticed is that if we combine demand generation and services together, it has really created an opportunity that not only do they get the information, but also access the services together. Otherwise, we have also noticed that there are usually gaps when it comes to just creating awareness and the generating demand, but the services are not made available at the same point. But this time around, when the CRHPs and community health workers create awareness and generate demand, and at the same point provide the services, this has really improved the access to services, particularly for the young people. And also working with the parents, we have seen that some of the misconceptions and the fears that the parents have always had have been cleared, and they're becoming supportive for their young ones to access services. So basically, that's what I can say for now. The story is really a long one, but in a nutshell, that's what it's pointing at. Thank you.
Thank you very much, Donald, for that. And we really appreciate you making the effort during your travels to make yourself available. It's truly appreciated. I think involving young people along with their families is definitely a unique approach that will yield the link to services, and SBC can certainly amplify the effects of service delivery. Thank you so much for your story. I'd like to give another minute back. Mariam, are you able to connect?
Yes, I think it's okay. Oui. Donc, ce qu'il faut retenir ici, c'est qu'avec l'approche TIGI, on a utilisé plusieurs stratégies de SBC et on engage les personnes influentes et les groupements influents, les hommes et les femmes, et les amène dans un cadre de discussion et diffuser les idées de ces discussions-là afin d'influencer d'autres personnes et aussi afin de créer cet environnement favorable. Pour cela, il y a des communications interpersonnelles. Aussi, on utilise les médias comme la radio afin de toucher plusieurs personnes. Ce qu'il faut retenir ici, avec cette approche SBC que nous avons utilisée dans TJ, nous avons pu amener des acteurs qui étaient réticents au départ, mais avec leurs implications et avec aussi la diffusion de l'entourage, à être maintenant les acteurs, sinon les défenseurs, pour soutenir l'utilisation des méthodes de planification familiale par des hommes et des femmes. Les résultats ont montré qu'on a eu une augmentation d'utilisation des méthodes modernes de PF et une réduction d'utilisation des méthodes traditionnelles, vu qu'il y avait beaucoup de cachettes. La surprise est que aussi cette approche a pu toucher même des jeunes et des adolescents. Quand on a fait une recherche pour voir la durabilité, il est sorti que maintenant même les mamans commencent à discuter avec leurs filles afin de les préparer et éviter des grossesses précoces. Donc voilà l'approche TJ en quelque sorte. Présentement, on est au Mali, ça s'intègre facilement dans plusieurs domaines de développement qui n'est pas forcément que de la santé comme eau, hygiène, assainissement, aussi l'éducation et la nutrition. On a fait l'expérience et les résultats ont prouvé que c'est efficace. Donc, ce que je vais dire pour take away, c'est que les gens, quand on fait SBC, c'est important de faire le renforcement de la capacité du staff. Parce que comme beaucoup de gens sont habitués à passer l'information, c'est-à-dire agir seulement sur la connaissance, alors qu'on a vu que les connaissances, le changement de connaissances ne suffit pas. Il faut vraiment ajouter ces changements d'attitude et aussi d'impliquer l'entourage pour qu'on puisse avoir ces changements sociaux escomptés. Donc, je vous remercie.
Thank you. You really ended that on a perfect note. We have to move beyond knowledge and we have to get to the social norms, the attitudes, empathy, so many other aspects of it. And all of the staff and people involved in the program are critical to be engaged. We have about a minute left, so I would beg your indulgence to just give me 2 more minutes to just wrap up this session, this very exciting and informative and rich session, knowing you will be receiving the links to all of these great video stories and written stories. I cannot end without thanking a few people. First, a huge congratulations and thanks to all the organizations who've shared their inspiring stories with us. Really, thank you so much. The production of these videos has been through a process that took into account the technical content and the creative execution. So a big thanks to the organizations who provided the content and details, and to all those who reviewed and provided inputs to the scripts at various important points. But most importantly, to Theo Smith, senior producer, and Jean Bernard, producer at Radiant Media Collaborative, and their team for the incredible work that they have done on this. They've been responsive, flexible, and amazing. Also, a special thanks to Marcela Aguilar from Breakthrough Action for her guidance and hands-on support in making this event happen. We truly couldn't have done it without you. And I think the 2 people without whom this event couldn't have taken place for their long hours of drafting, editing, communicating, revising, and painstaking attention to detail. They've been the backbone of this event. From its genesis to the smooth execution. Kendra Davis and Olivia Carlson, thank you so much. And finally, for all of you for attending this launch and bringing your interest, enthusiasm to this event. And we hope you'll take these stories back with you and amplify them in your own circles and through your own media platforms to show more people the power of SBC in improving family planning and reproductive health outcomes in your programs. So we now turn this over to you. We will hear from us on social media and through the links. And thanks again for coming. Look forward to connecting with you again. Have a great morning, afternoon, evening.